But the reality is that we are responsible for creating a culture of safety together for everybody in the clinical area. We have to think not only about ourselves and our personal risk, but how exposure to these hazardous drugs persists in the work environment for everybody. And we have to be part of the solution for everybody, even if it's not something that we're personally really worried about being exposed to.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS, and today we're talking with AnnMarie Walton, Associate Professor and Dorothy L. Powell Term Chair of Nursing at Duke University School of Nursing in Durham, North Carolina, about updates to the 4th edition of Safe Handling of Hazardous Drugs, one of ONS's book publications. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, AnnMarie.
Thanks for having me.
You served as the co-editor of the book alongside Michaela Olson, who we recently had on the podcast to talk about the ASCO ONS safety standards. Can you tell us a little bit about the book and its background in clinical practice?
Absolutely. So it was really a privilege to be a central part of this book with Michaela. And I want to be sure to acknowledge that the reason we got to the 4th edition of this book at all is because of the giants that we have the privilege of standing on the shoulders of. And so that's Marty Polovich, who had the vision and put into work the vision for this book in the first place. She taught a lot to both of us, and Michaela has co-edited this text with her from the very beginning. I also want to acknowledge how unique and how valuable it's been to work on this book with Michaela, because we are a PhD and a DNP prepared team. Michaela brings true expertise in clinical practice and education, and she's actively on clinical units every single day. And I bring a familiarity with the research literature as well as my own experience as a researcher in this area. So together we make a really great team. We know that this book is used in practice sites across the country and increasingly around the world. And we have the privilege of answering lots of questions of ONS members routinely. And we've both also been part of writing guidance documents for ONS. And so we utilized as well some of those questions that have come to us, and we know what people want to know more about. So we've made sure that we've developed a book that would be the most helpful in clinical practice settings.
I love being able to take those messages and questions you've gotten from members and from nurses across the country and incorporating them, because then it becomes a book that's really for them.
Yeah, exactly.
Who's the intended audience for this book?
Like the prior editions, it's definitely intended for those who handle hazardous drugs. But what's different are 3 things. Number one, we recognize that more and more of these drugs are being given in non-oncology settings. So we're thinking about people who are giving them in long-term care facilities, in rehabilitation facilities, and in ICUs. And very often these are non-oncology nurses. We also recognize that more of these drugs are developed all the time and are now being given by some alternative delivery modalities. For example, PIPAC, pressurized intraperitoneal aerosol chemotherapy, is much newer than the traditional HIPEC, hyperthermic intraperitoneal chemotherapy, that we've written about in the past. So this book includes people who are practicing in locations where we have not included them before, and also people who are administering some of these newer drugs by newer methods. And then third, and most important to me, is that we consider in this book healthcare workers who are not nurses. So this is nursing assistants, environmental services workers, healthcare unit clerks or secretaries who aren't actually administering these drugs, but still have an exposure risk and have documented exposure in research studies. So this book is written to help include them and guide them as well.
That is so important. I think of the number of times that we try to educate the people who are not familiar with these medications and the side effects of them, and then not even understanding just the basics of that. So the more information we can give them, the better. What type of methodology was used when you developed this book?
I'm happy to talk about that. So as a researcher, and definitely with Michaela's appreciation of evidence-based practice, we started by engaging the ONS librarian, Carrie Moriarty, in a thorough review of the literature in this area. So we started with anything that had been published since 2014, which is when the review stopped for the third edition of the book. And we looked at literature between 2014 and 2023. It took us the better part of a year, honestly, reviewing and sorting that literature by our relevant chapters. And at the same time that Michaela and I were doing this behind the scenes, we were engaging really awesome expert chapter authors on those topics, and not all of whom are nurses. So we had professionals in pharmacy, in environmental health and safety, and in medicine. And then what we did once we had our chapter authors together was we sent a collated list of the most recent literature in the area to each of the chapter authors, and then really monitored to be sure that they were updating their chapters with what was most current. We also included things that they found that they brought to us, other relevant materials and resources that they found on their own. We sent them the third edition of the book to start from. We requested updates and changes with this supporting literature. And we went through 3 or 4 iterations of each chapter with each chapter author.
That is a lot of work, and that is a lot of literature to go through.
Mm-hmm.
What are some of the main changes to the fourth edition?
One key one, which we've already talked about, is all of the recent literature from the last 10 years. That was a big lift and really changed a lot of the tables. You know, we had a great table on adverse health effects. That's been updated. We had a great table on the literature on surface contamination. That's been updated. So lots of current data in there. But also, really importantly, we ensured that the book was in alignment with all of the most recent organizational position statements, standards, and recommendations. And there have been some big ones between the publication of the third and fourth book. So USP 800 is one that everyone knows about, and that became enforceable in November of 2023. That's been included throughout this book. The ONS HOPA position statement, which was most recently updated in 2022, was also folded into this book. NIOSH came out with 2 new guidance documents in 2023, and I had the opportunity to serve as a reviewer on one and a contributor to the other. Those 2 NIOSH guidelines have been folded into this book. And then the ONS chemotherapy and immunotherapy guidelines and recommendations for practice, which Michaela was a lead editor on and I was an author for, have also been folded into this text. So we were able to ensure that there's consistency across these 2 ONS books, but also that we're really writing from the most current standards and guidelines of NIOSH and USP as well. We also updated the content on closed system transfer devices. There's been a lot of advancement there since the third edition of the book. We've included a new donning and doffing procedure that ONS is now teaching in their chemotherapy and biotherapy provider course. We have an updated statement on alternative duty, which has been approved by the ONS board in 2023. And then we worked hard on our appendices in order to make them such that people could take them and use them right away, either to train other healthcare workers or to do patient and family education. So I would say, in a nutshell, those are all of the big changes in the fourth edition.
Wow, that's quite the overhaul. Moving a little bit to surface contamination, because these hazardous drugs are used so frequently in oncology, we know that surfaces where they're prepared and administered can be contaminated. It's an area that you've researched and written about. CJON recently published an article you co-wrote, and you also appeared in a video with CJON editor Johnny Watson on the topic, which we'll link to in the episode notes. What are some of the best practices to reduce surface contamination and healthcare worker exposure?
Oh, I love this question, and I hope you have lots of time because I could say a lot about this. I'll start first with that paper that was recently published and just kind of hit a couple of highlights from it. So what it did was it took a look at 2 inpatient oncology units before and during the COVID-19 pandemic to look at the impact of PPE use on surface contamination. And we sort of thought, well, this is a natural opportunity, right? People are probably using more PPE during COVID. And we hypothesized that if people wore more PPE, surface contamination would go down. It's just sort of what we've always been primed to think. And what we found actually was that PPE use did increase during certain activities, especially when handling anti-neoplastic drug contaminated excreta, because people were worried about coming into contact with body fluids. But the overall surface contamination on these units was not statistically significantly reduced. We have to be careful because it's one study on 2 clinical units, so we can't make lots of generalizable conclusions from just this amount of data. But it does suggest that PPE is important and still not enough in and of itself to reduce surface contamination. We've understood the NIOSH hierarchy of controls for years. And if we look at that hierarchy, it tells us that PPE is important, but also the least effective when it comes to controlling exposure. And what's slightly more effective is administrative controls, which are things like changes in our practices, more education and training, and then even more powerful than administrative controls are engineering controls. And these are your closed system transfer devices, for example, that are really important in minimizing exposure. So an important note about the study that I just told you about, closed system transfer devices were not in use on either unit at either time point in our recently published study. And so we feel like if there had been closed system transfer devices in use, maybe if education and training were slightly different, that we might have seen more of a reduction in surface contamination than we did, even though PPE use was slightly higher. We also know from some of our previous work and the literature that bathrooms are really contaminated and that we are under considering body fluids as a source of exposure. So when we think about what surfaces are contaminated, we have to not just think about the administration areas where we give the drugs, but think about patient bathrooms and floors all across the work area that have been shown to be contaminated. Our work and the work of other people supports that there's contamination even in places where the drugs were not administered, like staff bathrooms and staff break rooms, and on common phones and floors. So standardized education and training for all healthcare workers, not just those healthcare workers that administer these drugs, is really needed.
That is very eye-opening. So if the surfaces are contaminated and the contamination persists, what are some of the best ways to remove it from the surfaces?
This is a good question. And the 4th edition of this book has an entire chapter on decontamination and cleaning. And what we have learned and what we've known for a while is that there's not one agent that can perfectly decontaminate and remove all hazardous drugs. The literature tells us that bleach is the most efficient cleanser that we have, but there are some surfaces on which we can't use bleach. It's not appropriate. And we also know that bleach may need to be deactivated once it's used. So if I had to answer in short, what's your best cleanser? What's the most efficient and does the most bang for the buck? I would say bleach, but bleach can't always be used.
It's good to know. Another area that you focused in your research is excreta and toilet pluming. What additional guidance do you have for healthcare workers coming into contact with contaminated excreta?
This is a place that I, for better or worse, spend a lot of time. And I have a colleague, Tom Connor from NIOSH, who likes to joke when people ask him about his work. He says, oh, it's in the toilet. And so I'm going to steal that from him and say a lot of my research is in the toilet too. ONS has recommended the use of plastic-backed pads while flushing for years. And we saw it in the 3rd edition of the book when we went to update it. But as a researcher, I was really curious to know what the evidence was behind the use of plastic-backed pads. And it was hard to find, to be honest. Our team, and I'll talk about this in a couple of minutes, did a study actually looking at the efficacy of plastic-backed pads when flushing. But we knew, and we have come to understand, especially over the last couple of years, that toilet plume can be a significant source of exposure to anti-neoplastic drugs. And Tom Connor, Seth Eisenberg, and I have a recent paper from 2024 in the American Journal of Nursing all about the hazards that toilet plume can cause, not only to anti-neoplastic drugs, but to other viruses as well. But what remains to be sorted out is the best way to reduce that exposure. Our team conducted a year-long study in which we took a clinical unit and we had everybody use plastic-backed pads for 2 months. Then we gave them a little bit of time in between, and then everybody changed to the opposite condition. And when I say everybody, I mean all of the inpatient bathrooms where chemotherapy was being given. And we repeated this twice. we shared these results at a prior ONS Congress. And what we found was that plastic back pads didn't significantly reduce surface contamination in bathrooms. Again, just like the other study, this was small. This was 1 unit. But what was interesting to us was that we did an observation of cleaning, and we interviewed both environmental services workers, their managers, and nurse managers, and figured out perhaps some of the reasons why we think this might be the case. So we would definitely have to test this again in a larger sample, but we do know from the literature that the key is allowing less plume to leave the toilet to reduce the amount that can get onto surfaces. So again, this points to the need for what NIOSH would call an engineering control, and that's fairly high up on the hierarchy as being protective. So we recommend somehow covering the toilet and using PPE when exposure is possible. And we also recommend thinking through ways to reduce exposure in the first place. So having the patient flush independently is one way. Our research, and we also have a paper under review about this, has shown that contamination persists despite doing some of these things. So more effective cleaning of surfaces is needed. In 2 studies, our team found contamination with a drug that wasn't given to the patient, which suggests that it's either left behind from the patient before, after discharge, or it's tracked in by the healthcare worker. And in both cases, one of the solutions would be more effective cleaning.
That's quite a bit to think about. And I think a lot of us actually, like what you've mentioned, is something that maybe we might know about, but actually putting it into words is very important.
Yes. I also will just take a second to say, I think it's super important. And this is something I've been saying for a long time, even when my work was more with farm workers in the field. It is really important that we take off our work shoes. If I told you the number of floors that we found that were highly contaminated, even where a patient wasn't receiving drugs, it tells us that there's residue on the bottom of healthcare workers' shoes. And so it's important for you to keep your work shoes, and leave them outside in your garage or outside of your house, or, wherever you leave them, so that you're not bringing that into your home and tracking it around as well.
That is a very good point. And I think that transitions into my next question for you, because it's talking about things in the home. So we know that patients are receiving anti-cancer therapies in their home increasingly more commonly, especially since the pandemic. Can you describe some of the main education points for patients and their families and caregivers regarding hazardous drugs in those settings?
I think we do a good job of thinking about the life cycle of the drug when we're in a hospital setting, like what happens to the drug from the minute it comes in and shipping and receiving, all the way through when it's taken down from the IV pole and disposed of, and when we handle the body fluids of those patients. But when the same life cycle applies, we just have to think about it in the home setting. So first, when it comes into the home, I think a good question to have families and caregivers think about is, are you storing it separately from other things? It should be stored separately. It shouldn't be in the kitchen next to your food, for example. Is there a spill kit? Even in the hospital setting, we always keep a spill kit anywhere where there is a hazardous drug. And so the same is true at home. Is there a spill kit that got delivered with the drug? Does the patient and the caregiver know how to use it? In the hospital setting, administration is often done by a trained professional, and sometimes that's true in the home as well. But then there need to be instructions left behind, both in the healthcare system and at home, about how to dispose of that drug. And then we think about the next aspect of that, which is toileting. And at home, just like in the healthcare setting where we have staff and caregivers use a different bathroom, the same thing should be done at home if it's possible. Not allowing others to come into direct contact with the body fluids of someone who's receiving these drugs for at least 48 to 72 hours and sometimes more. And we do a good job of this in the 4th edition of the book as well, explaining the half-life of a drug and how long it takes for a person to excrete something, and why that 48 to 72 hours is really just a general parameter and not a true guideline, because it depends on a person's metabolism and the drug itself and the half-life of the drug and other factors. There should also be special education about the risk for people who are pregnant, lactating, or trying to conceive, and exposure to children, which becomes even more important in the home setting.
We spend weeks training our nurses how to administer chemotherapy and how to protect themselves. And then we send a patient home with an hour of education about managing these things.
You're absolutely right.
Just a couple more questions for you. What unconscious or implicit biases have you heard healthcare professionals say about safe handling?
I don't know what the right catchphrase is for it. Ageism is sort of what comes to mind, but in a reverse ageism sort of way. So something that I hear a lot as I talk to folks, especially nurses who have been administering a long time, is they say, well, I'm past my childbearing years. Like I'm no longer worried about my own exposure to chemotherapy, or I administered for this many years and nothing happened to me. We're actually practicing much more safely than we did at the start of when I was practicing. But the reality is that we are responsible for creating a culture of safety together for everybody in the clinical area. We have to think not only about ourselves and our personal risk, but how exposure to these hazardous drugs persists in the work environment for everybody. And we have to be part of the solution for everybody, even if it's not something that we're personally really worried about being exposed to.
That's a great point. What are some common misconceptions about safe handling?
I think people underestimate how much of a contribution body fluids and excreta play to exposure risk. And I think it's why we've focused for so long on nurses and pharmacists as the people who administer and prepare the drugs respectively, but why we've left out other healthcare workers from this conversation. So why we've left out nursing assistants who are the ones predominantly handling those body fluids, why we've left out environmental services workers who are cleaning and coming into routine contact with these surfaces. I think it's because we've underestimated how much of a contribution body fluids and excreta play to exposure risk. I think it's also why we've been comfortable leaving nursing assistants and EVS workers out of standardized education and training that we require of nurses and pharmacists. And I think that really my personal soapbox is that needs to shift. I think also people overestimate the efficacy of daily and discharge cleaning if it's not carried out properly. And our recent study that's currently under review will talk more about that, but we definitely found room for improvement here. I think people think that patients and caregivers, and we talked about this a little bit already, don't need to know as much if the administration is happening in a clinic or in a hospital setting, that the time for risk of exposure is over once they go home and the drug has been infused. But the reality is that they still need to know about exposure to body fluids at home and also need to know for administration in the home and for future admissions and treatments. So I think those are some of the key ones: the contribution of body fluids and excreta, the efficacy of daily and discharge cleaning, and then the need for better patient and caregiver education for home.
What's something about this topic that's not often discussed, but you wish people knew more about?
Again, I feel like I'm totally on my soapbox here, but I feel like people don't know how contaminated toilets are and how contaminated floors are. And I've already told you my tip about leaving your work shoes outside. But I think if people were more aware that the toilets and the floors are often the most contaminated places on a unit, there would be more attention paid to people who are coming into contact with those surfaces and bear a lot of the exposure risk. I'll mention too, we have another paper that's under review, this one not at a nursing journal, but we've done a scoping review of 73 studies internationally that have looked at surface contamination. And we're trying to look at across all of these studies, what are the most contaminated areas? And I'll tell you that toilets and floors rank very high on the list. So again, it's reason to have concern about this and something that I wish people knew more about.
I think that's excellent. I think what you've really pointed out a lot is that we've done a lot of focus on training the nurse and making sure that they understand this. But as you pointed out, there are so many more people that are involved in this, and we need to just start rolling that out into more and more of these places. What additional training or education do oncology nurses need to stay current on this topic?
Well, as I mentioned, these drugs are coming off the market every day and into practice. The list is constantly changing of what's considered a hazardous drug and what's available to us, as well as the way that it's administered. So Michaela especially did a really great job with the administration chapter in this book, making sure that there's up to the minute content on all of these newer, innovative administration modalities. And also because we've increased our use of closed system transfer devices over the last 10 years since the last edition of the book, we talk a lot more about how to use them and how to use them properly, complete with photos. So I think in order to stay current, people need to be thinking about these new drugs, the increased number of settings that they're being given in, the new ways that they're being administered, and then also closed system transfer device use.
So that's education for nurses. What sort of resources are available for patient and family education?
So within the book, we have an entire chapter, just like we have an entire chapter for healthcare worker education. We have an entire chapter for patient and family caregiver education. And so we review in there what should be gone over prior to discharge, or if it's a clinic, prior to heading home. And we also include, as I mentioned before, we updated all of these appendices to include handouts that can be used to do education with patients and caregivers so that people don't have to reinvent the wheel.
That's always handy. What are some additional resources for healthcare workers who'd like to learn more information about safe handling of hazardous drugs?
In addition to the chapter in the book and then the appendices, and this one for healthcare workers has an appendix that can be used for a hazardous drug administration practicum if you're training others to handle HDs in the workplace. It also has an HD safe handling checklist that can be used for annual training and annual competency. But in addition to what's in the book, Michaela and I and several of the people who worked on the ONS HOPA joint position statement back in 2022 authored a series of resources for our members that are in the ONS Learning Library on the ONS website. And it includes guidance. For example, one that I wrote was all about toilet flushing. And that really helped give our members the latest information that was available between the third edition of this book, 2014-15 timeframe, and this one. So those resources also go in depth on a lot of these topics and are written by content experts.
I have to say, after talking with you, I am so jealous of all my clinical nurse specialist colleagues who are still in clinical practice. I wish I had had all of these resources when I was doing this.
Thank you.
Thank you so much for talking with me today, AnnMarie. Do you have any final comments for our listeners?
I just want to share that I'm really excited and proud of this fourth edition of the book. I love that we are finally talking about and including all healthcare workers that come into contact with hazardous drugs. And I think that's really important for health equity. I think we've done a good job making sure that the evidence is the most current, that we're in line with the most current recommendations nationally, and that the resources that we've shared can be readily implemented in practice. We're really proud of the book we've published, but we're even prouder of the people who care for those with cancer every day. And this book is really for you.
Thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.